So welcome everyone. You can always see who the truly motivated people are, who are truly motivated by science, because they are the ones who are here at 8 a.m. So very proud of you all for being here. And you should be, because we have an extremely exciting session with promising researchers that are going to represent the juniors here today. And this is actually an extra exciting session because it's a tournament. So we are going to be giving away prizes to the best speaker. So make sure that you have the app of the Congress registered on your phone. And also make sure that you're registered. If you're not registered on the app, you can't vote, and that would be a shame. So today we'll have interesting talks for you. And we're going to start with the clinical talks. And before we start, short introduction about myself. I'm Irene de Boer. I'm the chair of the junior group, which is the group that put this program together. And now enough about me. We'll move on to the important people of the day. And the first one is Marina Romozzi. And she will talk to us about a nomogram for the prediction of response to anti-CGRP, mAbs, and the CGRP score.
Good morning, everyone. And thank you very much for the introduction. And thank you for the opportunity to present this work today here. These are my disclosures. And I'm Marina Romozzi. I'm an adult neurologist, and I'm also doing my third year of PhD in neuroscience. So, monoclonal antibodies anti-CGRP have revolutionized migraine care. However, still, approximately 30% of the patients do not respond to these novel treatments. And due to restricted reimbursement criteria, long-term treatment cycles needed for most of the patients and their costs, it is essential to identify predictors of response. And nowadays, machine learning algorithms are increasingly used in migraine medicine to support diagnosis, for treatment prediction, and they use a large amount of data by data-driven learning. So, based on these premises, this study aimed to predict the response to monoclonal antibodies anti-CGRP after 12 months using demographical and baseline data. And then we aim to create a nomogram. For those who are not familiar with the term, a nomogram is a graphical calculator that translates a statistical model into a visual tool to predict the probability of a response or probability of a certain outcome. So, we conducted an observational prospective cohort study, including consecutive patients treated with subcutaneous monoclonal antibodies anti-CGRP, recruited from 2 Italian centers. And then we also recruited a validation cohort from another center. And we collected demographical variables and also baseline clinical variables, including headache frequency, headache severity, of course, migraine diagnosis. And our outcome measure was the reduction of more than 50% of monthly headache days at month 12 of treatment. So, we started with these, maybe I point there, with these 11 variables that were chosen according to the clinical relevance and also the availability across multiple clinical settings. And they were baseline clinical variables and demographic variables. Then we used these variables to fit and tune several machine learning models, and we chose the model with the best performances. We then validated our model against an external cohort, and we got the performance metrics for our model, including precision, recall, and F1. And then this model also generated coefficients for each variable. We then used these coefficients to build a nomogram. So these are our study cohort, and as you can see, we recruited patients from Italy, from Rome, and from Florence, and it included 429 patients treated with monoclonal antibodies anti-CGRP, and also a validation cohort of 109 patients from another center in Rome. This validation cohort was never exposed to the first cohort. And now the best model with the best performances turned out to be a logistic classification model. And this model with this outcome measure, the 50% reduction of monthly headache days, had an average precision of 73%, same for average recall, and an average F1 score of 70%. And then the model also generated a coefficient for each variable, and with the, of course, the respective weight of the coefficient, with positive signs indicating an association, indicating a positive response, while negative coefficients indicated a negative association with the response. And then we used these coefficients to finally build this nomogram. So, what is this nomogram and how can we actually use it? So let's start from a patient that might come to our clinical practice. So for example, a 36-year-old male with chronic migraine, no medication overuse, no aura, and then you can see MHD of 15 and other MAIDAS, H86, etc. So, will this patient respond to monoclonal antibodies anti-CGRP at month 12? Let's discover it. So, we have to map now each feature from each variable onto the nomogram. And let's start to take a look at the upper part, so the points axis. And I will directly give you an example, so it will be easier. So our patient was a male. So we have to map, in this case, we have to identify these features, so male. And then we have to draw a vertical line that goes upward until it intersects the point axis. So male, and we draw the vertical line, and in this case, male is 0 points, unfortunately. And then we do the same for all the variables, and we have a point for each variable. And then we have to sum all these variables, like all these points, and in this case, we have a total score of 316. And now we have to look at this bottom part in the total point axis. So we locate our total score, 316 in this case, and now we have to draw another vertical axis going downward in the probability axis scale. And in this case, we have an 82 probability of response at 12 months. So we created the first pen and pencil tool to predict the response to monoclonal antibodies anti-CGRP at 12 months. And it complements the existing literature where there are other machine learning-based models. For example, I present this one that we also created with our group. This is a computer-based model that integrates several variables, and you have to use a computer. But in this case, the advantage of the nomogram is that it's very user-friendly, as you could see, can be applied manually, and it's so applicable in all settings. So both approaches can be combined to enhance decision-making in clinical practice. So to conclude, we developed the first machine learning-based nomogram to predict the response to monoclonal antibodies anti-CGRP, and it offers a scoring system for the potential for manual application in clinical practice. However, prospective validation studies of our nomogram are needed. Thank you very much.
One very quick question. Your validation cohort was also Italian-based. Do you think that's a problem if you want to actually use your model outside of Italy?
Thank you very much, Arena, for the question. Yes, it was another Italian cohort, but we are really thinking now to validate the two models that we created with external cores from other countries in order to have a better generalizability. Yeah, thank you very much.
So in my rush to ask my question, I forgot my piece of paper. So it's time for our next speaker. And our next speaker will be Gloria Kleinschmitt Westhofen, who will talk with us about modulatory effects of prayer on pain sensitivity in migraine, a randomized single-blind crossover study.
So, good morning everyone. I'm honored to be here today talking about this topic, our research on the modulatory effects of prayer on pain sensitivity in migraine. I have no conflicts of interest, and I am a naturopathic doctor here in Brazil. And here you can see more information about myself. So, why is it important to talk about spirituality and pain, specifically in migraine? We know that for the migraine treatment, we have both acute and preventive options, mostly pharmacological, but non-pharmacological options are also an important thing and a reality in our world, since chronic pain management is influenced by behavior factors, and this includes relaxation, mindfulness techniques, and spiritual practices. And in the literature, we have results that demonstrate that spiritual practices and religious rituals like prayer are associated with the activation of specific brain regions involved in pain modulation, like prefrontal cortex and the amygdala. We also have in the literature some studies that suggest the analgesic effect of prayer, but these studies have some limitations. They often give a specific type of prayer that the participants didn't have the habit of performed, or use subjective outcomes only to evaluate the pressure pain threshold and other things. So, our objective in our study was to evaluate the effect of a well-established familiar prayer compared to a non-spiritual text reading, the control for the prayer intervention, on pain thresholds in individuals with and without migraine. For this, we use the pressure pain threshold that is an objective outcome. We measured 8 cephalic points before and after each intervention. So we measure with a digital algometer at right and left occipital, temporal, and masseter, plus frontal and vertex. So this was a randomized, single-blind crossover study. We had 2 visits, and all participants completed both interventions, a 10-minute familiar prayer in one visit and a 10-minute reading control text. We included adults diagnosed with chronic or episodic migraine, and also individuals with no headache diagnosis. And for the randomization and for the blinding, we used 2 opaque envelopes, each containing 1 intervention. And if in the first visit the person randomly choose the envelope with the text reading, in the second visit they perform the remaining intervention, in this case the prayer. And all participants registered in an online form in both visits what intervention they have done, and the evaluator didn't have access to this register. Also, after the prayer intervention, they categorize it if they performed a Thanksgiving prayer, a petitionary, meditative, or confession one. So we can analyze if different types of prayer have different analgesic effects. Maybe Thanksgiving is more analgesic than other types of prayer. This is our results. We included 105 participants, 55 in the migraine group and 50 in the non-migraine group. We had 9 religious affiliation declared, mostly evangelical, Catholical, and Kardecese spiritists, but also agnostic and person with no religion participate. They feel comfortable performing a prayer, so they participate too. And here we can see the principal results, the changes in pressure pain threshold before and after interventions in both groups, migraine group and non-migraine group. And after prayer, when compared to the reading intervention, prayer statistically significantly increased the pressure pain threshold by about 47 kilopascal in the migraine group and by about 87 kilopascal in the non-migraine group. And interestingly, after reading, the pressure pain threshold have a marked decrease in the pressure pain threshold in both groups. So, in conclusion, prayer significantly increased pain threshold when compared to a neutral reading text in both migraine and non-migraine participants. These findings provide evidence that spiritual resources may act as an immediate modulator of pain and open the door for further analysis, like does having the previous habit of praying during the ictal phase of migraine enhance its analgesic response? What is the optimal duration of prayer-induced analgesia? Maybe 10 minutes it's okay, but maybe it's too short or too long. And do different prayers modalities like petitionary, thanksgiving prayer modulate pain in distinct ways? Exploring these questions could help us integrate spirituality into the multidimensional care of migraine. Thank you so much for your attention.
If not, I'm gonna hog all the questions.
Yeah.
I'm completely fine with that. I wanted to ask you, the people that did not have a religion of their own, did they also show an effect?
Yes. I can't say exactly what the effect, but when the medium of the participants, they also show effect, because we don't give a specific type of prayer with a religious exactly prayer. Maybe the person can perform their prayer, thanksgiving their life, their opportunities, I don't know, things like this.
And is it possible that the placebo effect plays a large role here?
Sorry,
That there's a oh, sorry, I'm already over time, so we'll have to come back to this later and we'll discuss it further. Thank you so much for your talk.
Thank you.
And with that, we are already reaching the third speaker. And now I would like to ask Keiko Ihara to come to the stage. She will talk to us about estrogen-containing hormonal contraceptives and vascular risk in women with migraine, a nationwide health record database study, and also get your apps ready because we are about to have the first voting. No pressure.
Hello everyone. First of all, I want to thank the scientific committee and the junior group for choosing this abstract for this session. It's a true honor to be here. So these are the disclosures and a little bit about myself. My name is Keiko Ihara. I graduated from medical school back in Tokyo, Japan, where I started research of a headache under the mentorship of Dr. Takizawa, and I'm at Mayo Clinic in Rochester, Minnesota, the United States, under the mentorship of Dr. Chen. And let me start by sharing information about current guidelines. So migraine with aura is a very well-known contraindication to estrogen-containing combined hormonal contraceptives. And the main concern here is the increased risks of vascular events, which depends on estrogen levels. And it's important to note the dosage of estrogen in modern contraceptives is substantially lower than when contraceptives were first introduced in the 1960s. And additionally, many studies did not include direct comparison between migraine with aura versus migraine without aura in previous literature. So our goal here was to investigate the risk of vascular events associated with modern contraceptives and migraine by comparing those who used contraceptives and those who didn't in the overall migraine population in patients with migraine with aura, migraine without aura subgroups. We also wanted to compare between migraine with aura versus migraine without aura in those who used contraceptives and those who didn't. So we used this nationwide de-identified huge electronic healthcare record database, including more than 120 American patients. And we included female patients aged 18 to 45 with a migraine diagnosis who are actively treated for migraine with at least one prescription of migraine-specific medications within 6 months. In terms of endpoint, we used this composite outcome of ischemic stroke, myocardial infarction, deep vein thrombosis or pulmonary embolism. And not to miss a stroke diagnosis code here, we also included intravenous thrombolytic administration such as tenecteplase and TPA. For statistical perspective, we used high-dimensional propensity score matching to adjust for potentially confounding factors such as demographics and comorbidities. This is the demographics of our data. So we included more than 5,000 patients in those who used contraceptives. In the other cohort, we had more than 21,000. And here, you can notice that those who used contraceptives were a little bit younger compared to the other cohort. But again, this was adjusted with propensity score matching. In terms of races, the majority were white. However, we also included other races in both groups as well. And in the overall cohort, the incidence of vascular events was 2.44%, which is very low reassuringly, and this is also consistent with previous literature. And this is the main result of the comparison between those who used contraceptives and those who did not. We didn't see any statistical difference between the two groups, either in each type of event and also in the composite outcome. This is the survival probability of just overall outcome, and again, there's no statistical difference between the two groups. We did the same analysis in migraine with aura and migraine without aura subgroups, and there were no statistical difference between the two groups either. Then we moved on to the comparison between migraine with aura and migraine without aura. First, when we compared between migraine with aura versus migraine without aura in those who used contraceptives, there was no statistical difference between the two groups. However, when we did this analysis in those who were not exposed to estrogen, those who were not prescribed contraceptives, there was statistically higher incidence of the composite endpoint in migraine with aura compared to migraine without aura, with a hazard ratio of 1.34. Here, the dark blue shows the migraine with aura cohort, and the gray shows migraine without aura with statistical difference. In terms of the breakdowns of the event, acute ischemic stroke was the only one endpoint that showed statistical difference between the two groups. So how to interpret this study? So first, the use of contraceptive was not associated with significant increase in vascular events in the overall migraine population, migraine with aura, and migraine without subgroups. However, another comparison showed significantly higher incidence of composite endpoint and acute ischemic stroke in migraine with aura compared to migraine without aura, only in those who were not prescribed contraceptives. There are many strengths to our study. This is a real-world large-scale database study with high-dimensional propensity score matching, but there are several limitations here as well. We didn't have information on estrogen dosage. We used diagnostic codes for migraine and vascular outcomes. There are several potential biases here as well, such as access to healthcare and selection bias in those who are prescribed contraceptives. To conclude, aura was associated with a significantly higher risk of vascular events in those who are not exposed to estrogen and contraceptives. Interestingly, exposure to modern contraceptives did not significantly increase the risk of vascular events in migraine, migraine with aura, and migraine without aura subgroups. And I want to emphasize more studies in this topic, ideally with prospective design and big scale, are necessary to reassess the vascular risks associated with modern contraceptive use. And lastly, I want to acknowledge my wonderful co-authors and my great mentor, Dr. Chen. Thank you very much for your attention.
Thank you so much for your excellent presentation. One quick question. Yes, we have one person.
Thank you for that presentation. Did you look at the subgroup of patients that were smokers? And what
Please start again so she can hear the question.
Thank you very much for that wonderful presentation. Did you look at the subgroup of patients that were smokers and the impact of smoking in combination with use of combined oral contraceptives?
That is an excellent question, and I am really interested in that perspective. However, current electronic health record does not necessarily or accurately record smoking status in most of the cases. So that was the limitation of our study too, but I'm hoping to get into that, dig deep into that perspective in future studies as well. Thank you very much.
Okay, those were our first three talks, and I'm Very happy that you're all voting with me, because it's pretty difficult, I would say. So for some of us who are not so very good with apps, such as me, I figured we do the voting together. So the voting should now be open. So if you go to your IHC app and you go to programming, then you can go to the Congress, and then it's the first activity of today, because you were luckily here early. If you click on it and scroll to the bottom, you get a quiz button. And then you click on the one thing available, and you should be able to vote. So we'll leave the voting open for 2 minutes for those of you who still had to register or still had to find the person that you like best or are still in doubt. And at the end of all the presentations, we'll reveal the winner. So I'm sorry, ladies, but you have to be at attention for a little bit longer. Okay, I think everyone who's still on their phone is checking their WhatsApp, so I think it's time we continue. So we now had 3 excellent clinical presentations, and it's now time to move on to the second part of this excellence tournament. And for that, I would like to call the first basic science speaker to the floor. This is Adriana Della Pietra, and she will talk with us about chronic prazosin-reduced headache symptoms through lymphatic flow enhancement. Thank you.
Okay, good morning everyone. Bom dia a todos. So today I'm going to talk about how chronic prazosin can reduce headache symptoms via the enhancement of the lymphatic flow. So these are my disclosures. First of all, what's the lymphatic flow? So the lymphatic flow is a network of perivascular spaces in which the CSF, so the cerebrospinal fluid, flows. As you can see here, in this case, we inject a green fluorophore inside the cisterna magna of a mouse, and we can visualize live how the cerebrospinal fluid flows. And together with this, we have a clearance of the brain, especially during the sleep, from an accumulation of solutes, including CGRP, whose accumulation could generate the development of chronic headache. What we have seen is that in a preclinical mouse model of TBI, so traumatic brain injury, is that if we drop a weight on the head of the mouse for once a day for 3 consecutive days, this mouse represents a trauma model, and what we saw is that after the trauma, the mouse has a decreased lymphatic flow. In particular, if you look here, you can see that in an anesthetized mouse, which simulates a sleeping mouse, of course we cannot tell the mouse to go to sleep. So in an anesthetized mouse, there is a higher lymphatic flow. As you can see, the fluorescence is higher compared to an awake mouse. This is the physiological function of the lymphatic flow. When we induce the TBI, especially in the awake mouse, the lymphatic flow decreases. So we can say that the lymphatic flow is impaired by the trauma. Now, what can we do in order to bring back the situation to the physiological condition? So because a high lymphatic flow during sleep has been associated with a low noradrenergic tone by Nedergaard and colleagues, our aim is to use prazosin, which is a drug already used for hypertension, an alpha-1 noradrenergic antagonist, in order to reduce the lymphatic flow, to reduce the noradrenergic tone, increase the lymphatic flow, so it can clear out the CGRP together with other solutes, and then treat headache. In particular, we have seen at the level of the lymphatic flow, always in mice, that prazosin can indeed increase the lymphatic flow. As you can see here, in awake mice, prazosin have higher fluorescence comparable to the sleeping mice state. In the awake mice, physiologically, the lymphatic flow is instead low. So overall, prazosin administration can increase the lymphatic flow. And this interest in prazosin has been supported by a small clinical trial in veterans diagnosed with post-traumatic headache, where administration of prazosin was able to decrease the frequency in headache. But what's the mechanism behind that? And so we go back to our beloved mice here. We use von Frey, which is a test to measure allodynia, which is a non-painful stimulus in the periorbital area, which is perceived as painful if the mouse has been pre-sensitized, in this case, by the trauma. So we use the trauma, and then we administer prazosin in the drinking water 2 weeks after the trauma. So as you can see here in the graph in the bottom, before the trauma, all the mice, regardless of the group, because they were not sensitized, they are fine, so they are at the top of the graph, so there is no pain. But instead, after the trauma, immediately after, the mice that had TBI drop, so they are in pain. But this acute pain, like in patients, wears off with time, and they will have a headache once in a while, which we induce with a very low dose of CGRP, which is a subthreshold dose. As you can see here, is a 0.01. Now, this dose in sham mice that were not sensitized by the trauma doesn't produce anything. But in mice with the trauma, this subthreshold dose produces pain. As you can see, it goes down. Instead, in the sham mice, a much higher dose, 0.1, is needed in order to induce the same kind of pain. After this test, we administer prazosin for 6 weeks, and surprisingly, what we saw is that not only the TBI mice were rescued by prazosin in the subthreshold dose, but also the full dose mice were rescued. We were supposed to put it in there as a control, but it turns out that also that mice are rescued. So what is the mechanism by which prazosin can rescue both CGRP-induced cephalic allodynia? So we go back to the glymphatic flow, and what we see, very interestingly, is that the CGRP by itself, so without any trauma, is responsible for a decrease in the glymphatic flow at the level of the cortex. And the prazosin is able to restore the physiological level of the glymphatic flow, which was reduced by CGRP. So overall, we have discovered that both MTBI and CGRP can impair glymphatic flow, which can be improved by prazosin, and that prazosin in a chronic setting can rescue the CGRP-induced periorbital allodynia in both the post-traumatic headache and in migraine preclinical model in mice. Of course, in the future, we still have to test other agents that can regulate the noradrenergic tone, like non-penetrant blood-brain barrier antagonists. And we are planning also to repeat the experiment in mice that have the glymphatic flow impaired via the aquaporin 4 channel knockout. At the same time, we want to monitor sleep because the glymphatic flow function is so intertwined with the quality of sleep. So I want to thank my PI, Andrew Russo, and Adisa Kuburash, who helped me throughout the project, and our collaborators in Seattle. Thank you, everybody, and thanks to the Junior Group and the International Headache Society to let me present here.
Very well done. Would anyone like to ask a question? I'm sure they are there, but is someone who would like to ask them right now? Okay. Oh, yes, we have a question. Could you, mic that way? Thank you.
Hello, everyone. Actually, I'm so happy, and I really appreciate your great presentation. Thank you for sharing your knowledge, experience with us. My question is about how did you evaluate the mice behavior after traumatic brain injury, and do the mice all trained before or not?
So,
thank you.
Yeah, thank you for the question. So yeah, the mice are trained, so acclimated for 1 full week. In this case, I showed CD1 mice, which are the white mice. They're trained to be in a cup because of course in the beginning they don't want to stay in there, and also they are trained to the vicinity of the filament, because in the beginning they will be like, what's going on? Like, but once they are acclimated, if they do not have any sensitivity in the periorbital area, they will just sit there and literally not move at all. But instead, if the mice have been sensitized, so with, after the trauma, for example, the day one after the trauma, they will be extremely sensitized, and they will swing at the filament or shake because they really cannot stand it. As for how we evaluated in the trauma, so we first baseline the mice, as I was showing the first dot, before the trauma, so to be sure that all the mice don't have any sensitivity to begin with. And then after the trauma, we evaluate both sham mice and TBI mice on day one. And usually on day one, there is acute pain in all TBI mice, while sham mice are not experiencing this sensitivity. And then we evaluate every 2 weeks with the subthreshold CGRP, as I was showing in the graph.
Thank you.
Okay, moving on to our next speaker. We have someone who will talk to us about nuclear paraspeckle assembly transcript 1 is crucial for photophobia behavior in mice. And this will be presented by Xuan Huang. Please come to the floor. There you are.
Okay, good morning. It's my great honor to present our work in the International Headache Congress. I'm Zhuan Huang, a PhD student from Xi'an Liverpool University in China. Today, I'm specifically share with you our recent finding on the role of long non-coding RNA, nuclear paraspeckle assembly transcript 1 or NIT1 in migraine-related photophobia. Here is my disclosures. And to begin with, photophobia is one of the most disabling symptoms of migraine, affecting over 80% of migraineurs. It is known that trigeminal ganglia plays a central role in the photophobia behavior, including releasing neuropeptides, cytokines, and regulate messenger RNAs. Transcriptome analysis showed messenger RNAs such as KCNK12 ion channel and hormone and receptors are crucial in light version by sustaining TG sensitization. Moreover, the majority of the transcriptome are non-coding RNAs whose role in photophobia is still elusive. Consequently, this gap in knowledge led us to investigate the potential involvement of non-coding RNAs in photophobia. To address this question, we therefore established the mouse model of photophobia. For this purpose, we use intranasal administration of ubiquinol, a volatile activator of TRPA1 that plays a crucial role in migraine pathogenesis. In our study, applying ubiquinol allowed us for the first time to successfully induce the rapid onset, injury-free photophobia behavior in mice. Furthermore, compare with vehicle control, the relative value of total time in light and transition times were reduced, suggesting the light aversion behavior is induced and the mouse motor activity is reduced. Since TG is crucial in photophobia mechanism, we next focus on the TG and ask, are there any non-coding RNAs altered following the mouse light version? To this end, we extracted RNAs from TG and performed RNA sequencing. As a result, in the photophobia group, total 7 microRNAs were altered, 3 were upregulated and 4 downregulated. In parallel, there were 125 link RNAs were altered, 106 were upregulated and 19 were downregulated. Overall, these findings are consistent with the previous study that TG sensitization contributes to photophobia, and our result supports that the idea light version triggers profound alteration of non-coding RNAs in TG, facilitating light signal transmission. And among all these altered non-coding RNAs, we noticed that the majority of microRNAs were downregulated and the majority of link RNAs were upregulated. Is there any association between these two non-coding RNAs? Here naturally rises our next question: what's the role of these non-coding RNAs in photophobia? Based on the sequencing data, we focus on the NIT1. NIT1 is the only long non-coding RNA involved in the upregulated cRNA network. This upregulated network including the upregulation of NIT1 and the downregulation of microRNA 196. And specifically, we predicted NIT1 microRNA 196 axis regulating 10 previous unknown novel message RNA targets via cRNA network. Importantly, in our work, we observed significant upregulation of NIT1 in the TG following photophobia, as validated by both RNA sequencing and qPCR. Furthermore, bioinformatics mapping indicates that microRNA 196-5P binding site with NIT1. Finally, the dual luciferase string processes support the direct physical interactions between these two RNAs in vitro cells. Taken together, there's one question remains: would knockdown NIT1 affect mouse light version? To further test this, we used an AAV vector to globally downregulate NIT1 in mice 2 weeks before the behavior experiment, and take TG for histological examination and qPCR experiments. First of all, we examined the efficiency of AAV knockdown. Using AAV approach, the AAV vector infected mice TG compared with a vehicle control in both negative control and the AAV knockdown group, and successfully downregulate the NIT1 expression in the TG compared with two controls. Behaviorally, as expected, compared with vehicle, though negative control slightly improved the total time in light and transition times, NIT1 knockdown significantly increased the total time in light and transition times compared to two controls. Therefore, this finding indicates that knocking down NIT1 can alleviate mouse light aversion behavior and increase motor activities. To summarize, we established a rapid on-site, injury-free photophobia model involving profound alteration of non-coding RNAs in TG. Moreover, of all these altered link RNAs, NIT1 is the only upregulator in TG sensitization. We found NIT1 is crucial upregulated NIT1 that facilitate photophobia in the TG through interacting with microRNA 196. To our knowledge, is further evidence that link RNA contribute to photophobia-related mechanism. Therefore, this axis could be a potential therapeutic target for photophobia. Finally, looking ahead, we plan to include both genders and investigate additional components of the cRNA network. For more details, you can find our latest paper by scanning the QR code. In the end, I would like to sincerely thank my supervisors, team members, as well as travel grants from International Headache Society. Thank you very much for your attention.
Thank you so much. I had one very quick clarification question. NIT1, did you find it because you went looking for it, or was it the pathway analysis that led you there?
We found NIT1. We focused on the NIT1 because based on our RNA sequencing data, it was only upregulated, the only link RNA in our upregulated cRNA network, which is the majority of the altered non-coding RNAs, including the microRNA and long non-coding RNAs.
Okay, thank you so much.
Thank you.
Then I would like to ask our final speaker to the stage. Our final speaker is Armin Scheffer, and they will talk to us about TIM3 as a potential biomarker for migraine activation and chronification, the first results of a pilot study.
Yeah, thank you very much for the introduction, and I'm very grateful that I have the opportunity to present you our data here from a pilot study. 2 sentences about my person. I'm a physician in Essen, Germany. I worked there the last year in the psychiatry department as part of my residency to become a neurologist. So here are my disclosures, and the title is TIM3 as a potential biomarker of migraine activity and chronification. And the question is, what is TIM3? TIM3 is a so-called T-cell exhaustion marker, and you might know PD-1, especially in the field of cancer. And our idea was it might be has something to do with migraine, and what is the link between this? And the link is actually CGRP. So CGRP, which comes from neurons, directly can affect T cells. So released CGRP can, on the one hand, affect T cell differentiation about the amylin receptor, MY3, and also can induce T cell exhaustion markers like PD-1 and TIM3, and especially about worked this with the CGRP receptor itself. So, what is T-cell exhaustion? T-cell exhaustion, if you look at the normal way of, like an infection, T-cells get activated by pathogens and antigen-presenting cells, but during a chronic condition like cancer or like HIV infection, there might be some regulation that exhaustion marker can be induced, like PD-1 and TIM3, and binding to these markers, these cells get inactivated and exhausted. And there was a publication here in Nature where where investigated that melanoma cells were innervated by C fibers, and these fibers release CGRP, and T cells, especially CD8 cells, cytotoxic T cells, try to attack the melanoma cells, but the release from the C fibers induces TIM3 and PD-1 expression on these CD8 T cells, and the tumor is able to inactivate these cells by its ligands like PD-L1. And we thought about that, okay, when we have a migraine, also C fibers, pain fibers where CGRP is released, what happens with the immune cells there, especially with T cells? And our hypothesis was, okay, if we have a similar procedure there, and during chronification, during a lot of attacks, a lot of CGRP release, might be there a footprint on the immune cells in the peripheral blood, where we can measure a different expression of these T-cell exhaustion cells, exhaustion markers. So what we did is we collected blood from our West German Headache Center in Essen from patients, and we analyzed these with flow cytometry, and we correlate the disease activity, the monthly headache days, with the part of CD8 T cells which express PD-1 and TIM3. And we collected here 61 patients, and 30 patients had at least 15 monthly headache days. And this is the procedure for flow cytometry. You see on the right side the fluorescence -1 control, and on the below the actual measurement. And here's TIM3, here's PD-1, and we correlate this here in this graph, where in this figure you can see here the monthly headache days, and here the proportion of TIM3 of the CD8 positive T cells, and we saw a significant correlation between the monthly headache days and the expression of TIM3. Every point dot here represents one patient. This significance was not found for PD-1. And we also checked if there's some influence regarding age or the sex, and it was not found. So I come to my conclusion. What does that mean? TIM3 on cytotoxic T cells may serve as a potential marker, maybe for chronification, maybe for disease activity, or at least maybe for CGRP-dependent headache, as we can see that some patients do not respond to any CGRP-specific medication. But at this step, we cannot say that. Especially, we need further investigation, especially longitudinal control studies, to show if our results are reproducible. Are the MHDs correlate with the marker expressions, also especially in a longitudinal way, and are there any other influences that we couldn't check in this study way we did right now, like infection, autoimmune disease, autoimmune condition, or actually the effect of acute migraine attacks, and also the effect of co-medication. And I want to thank my head of the West German Heading Center, my professor Dagny Holle-Lieb, and also Professor Manfred Szydlowski, where I can use his lab. Thank you very much, and all my group.
Thank you so much for your excellent presentation. I'm going to steal the question. So you found a correlation of 0.3, I believe. Do you think we'll be able to use this as a biomarker with this correlation?
Not right now. So I think we have to investigate it a little bit more further. Especially we only collected blood from all patients from our headache center and just investigate, okay, can we find this? And I was surprised that we find something. So I think it's worth to show if this is a potential marker, but it could also be a dead end. So but we will see.
Thank you so much. Again, we have a very high level of presentation that we have to judge. So I'm lucky that you're all helping me. We do it the same way we did last time. We go to the activity and we vote. So when you're at the activity, you go for quiz. This time there are other options for you to pick. Is there a problem with the voting? Oh, okay. I see some people looking at me questionnaire. Is there a problem with the voting? Please come up. But if not, then I think you all had the time to vote. So we're going to be compiling the results. So very quickly we'll have them. But I will take the little time that while we're doing that to give a couple of announcements from the junior group. So the junior group has a lot of different activities. One of them is this excellent tournament. But another thing that we do is we offer research grants. And I would like to take this moment to announce that this year's grants have been allocated. And they've been allocated to Michelle Jaralia from New Zealand, to Olivia Gretsch from the UK, and to Subbalakshmi from Sukmar from India. And I really think that it deserves also very much a applause. And I very much look forward to the next couple of IHC congresses where they will share the results of their grants with us. The other announcement that I have to make is that there are junior committee members who are leaving us. I would very much like to thank Faridon, Ayush, Kwampo, Tatiana, Mohammed and Sojun, who have done a lot of excellent work for the junior group, but are now leaving our committee. And I also would like to take, another round of applause, they really deserve it. And I would like to take this moment to also thank some of our new members. Among them are Basit Chandri, Delena Ona, Mashito Kuchiku, Adriana Della Pietra and Anna Shuishki. They're not all here today, but those who are, please stand up so you can wave for a second to your other juniors. And I'm sure they will do their absolute best to represent you as well as possible. And with that, we get to the important part, the prizes. Well, I truly believe that you're all winners and should be treated as such because you were picked from a lot of abstracts. Some of you were actually the ones that got the most votes. So first we'll do the clinical presentation. I'm looking at the people in the back if they have the result. If not, I will just continue to keep talking. I'm completely fine with that. But you might not be. Is there... So of course we have to make certain that we show the right result, because it would be very sad if we show the person that didn't win and I would have to call them back on the stage. It's always so lovely, the technology, we can do so much with it, but then when it lets us down, we're stuck. So maybe in the meantime, while we get to show the slide, you can already bring me the trophy. Yes, okay, I get the thumbs up, so I think we're good to go. Please show me the winner. Or not. Oh. So this is the basic science part, which is completely fine. Adriana, please come forward.
Another dance-free night in a place called New York City.
So a well-deserved winner, and we have another winner from the clinical science. And also, Keiko, can you please come up to the stairs, to the stage? Also a trophy for you. But as I said, I truly believe you're all winners, so I would very much like to invite all the speakers to come to the stage so we can take a group picture. So with that, I would very much like to conclude this excellent symposium. Thank you all so much for being there, especially the people that were here at 8. It was very great to be here with you today. Oh, sorry, important news. If you're a junior, then please go to the plants in the back, because Carol has a shirt for you if you have not yet received one. So juniors who have not received a shirt of the IHC, please go to the back to receive your shirt now.